Good morning, George. It's Tuesday morning, and we are back at the podcast as we are most Tuesday mornings today with a great guest coming from your side of the country, right there in Long Island, New York.
Today we have Dr. Bradley Block. He is a local pediatric ENT, adult ENT otolaryngologist. And the title for his topic for today will be A Day in the Life of an ENT. Let's see what we have to talk about.
Dr. Brock is an ENT specialist or otolaryngologist, speaker, medical consultant, creator, and host of the Physician Guide to Doctoring podcast, an incredibly successful platform that speaks about what it is to be a doctor in 2024. Welcome, Dr. Block. It's a pleasure to have you.
I'm super excited to be here. Thanks so much for having me.
We always ask, why did you become a physician? And in your world, why did you become an ear, nose, and throat surgeon?
So for a physician, I couldn't think of anything else to do. And it wasn't like it was some calling that I was like, I've always been called. It was always in my heart to be a healer. It was genuinely, I just couldn't think of anything else that I would be good at that I could do. So I was like, okay, I think I'll try to get into medical school. I made it in by the skin of my teeth, off the wait list, one university. And there that started the started the journey. And then from then I couldn't get off the moving train that was our path, our training path. And I'm still on that train. So here I am. So that was medical school. Maybe not the most compelling reason, but it's worked out so far at least. And then as far as otolaryngology goes, we do cool stuff. Like we do really interesting interventions that often are like minimally invasive and yet are very effective. And for instance, like ear tubes, right? Because as you all are extremely familiar with, you can have a kid come in, a 2-year-old come in with speech delay. Maybe they've got one or two words, and it's because their ears are sucked in with fluids. It takes 5 minutes to put in a pair of ear tubes with not absent risk, but minimal risk. And the kid just starts speaking. So it's like stuff like that gets me really excited to do what I do. Now, on the other end of that, I know we're going to be talking about a day in the life of an otolaryngologist. My day is very different from a head and neck cancer specialist who spends many more days than me in the operating room doing large surgeries with free flaps and large resections. So the day in my life is going to be very different from, an academic head and neck cancer surgeon or an otologist or a facial plastic surgeon. We've got all these subspecialties in otolaryngology, and all of our days can be very different.
Yeah, it's an amazing specialty. I used to send someone to the ENT every week.
Used to.
I
Why don't you
don't,
send them to us anymore? We miss
well,
them.
it's called pneumococcal vaccination.
Oh,
A day in the life of the pediatrician, no matter where you were, unless you were in the critical care units, it was 5 otitis medias a day. Now it's one a week if you're lucky. It's really changed quite a bit.
The Prevnar vaccine has dramatically improved our lifestyle. We don't have to see as many sick patients. I have students that rotate in the office with me, and I don't have an ear infection to show them. Is that good? I guess it's good for
yeah.
public
Yeah.
health.
Listen, when I started training after the hip vaccine, so we didn't see nearly the number of epiglottitis that we used to. Do I know how to manage an epiglottitis? Yeah, I know how to manage an emergent airway for other reasons, but I'm glad I don't have to see epiglottitis. That's
Oh, I
this
know,
is this
right?
is this yes, it's bad in that you don't see the stuff that you used to see, but it's good because people aren't having those afflictions anymore. Like
Yeah.
we all want to be out of a job. That's great.
Yeah. Then strep bugs me to no end anymore because for the sake of being efficient, not effective, everybody gets a strep test. And it's a waste of time, money, and effort. You walk in there, they don't have pus in the tonsils, they don't have swollen lymph nodes. Tonsils are not enlarged. The kid's got a runny nose and allergic rhinitis, and now you're stuck. Here
Oh,
you
because
here's your the,
you're finding them
the
strep positive.
yeah, the medical assistant runs in the room excited, tells them you got strep, and that's it. You're not going to be able to walk that back. It's not the old strep that I used to see. The kid's got 102 fever, no cold symptoms, tonsils have pus, tonsils are swollen, nodes are tender. They look really miserable. And they open their mouth and it has this odor to
Smells
it.
of strep, yeah.
It
But you
smells
know
of
what? The
strep.
reason that is, Herb, is access to care. Back in the time when you were a little doctor, you would call the appointment, they'll get you in a week. Now you don't know how many kids come in. How long you've been sick? 3 hours. What's access to care? I've seen diseases progress in front of my eyes. Sometimes I feel like I have to be like a fortune teller, which way the illness is going to go.
Yeah. Yeah.
But
That's the point. Like they come in with a sore throat and they
Yeah.
immediately get swabbed. If you had just let it run its course for a day or two, 2 days later, they'd no longer have a sore throat. Now they'd have a runny nose and a cough, and you'd know that it was viral and you would never swab that patient. But
Right.
now you've got these kids that come in with these multiple positive swabs, and it's hard to tell how many of these kids are colonized, because you can be colonized. Let's say you're of
Right.
someone who just has strep that lives in their throat, right? And it's on the surface, but it's not invading. And so it's not causing them any symptoms. If you just took them at a random Tuesday and swabbed them, they'd be positive, right? We don't treat those kids. But now that kid has a cold, and the first symptom is pharyngitis. So the kid starts complaining of a sore throat. You go to the doctor, you swab their throat. Now they're strep positive, but not because the strep isn't causing the sore throat. And so
Right.
how do you know that's what's going on? What do you do in that situation? And so this is where, to your point, George, that access to care really can make it harder to know what to do. Who's going to argue that access to care is a bad thing, right? But it does, in a situation like this, can make knowing what to do
Harder.
challenging. And then what are you sending, like anti-streptolysin antibodies? And what do
ASOs.
you
Oh, yeah, I
do with
still
that
send
information?
ASOs
Like,
out. When somebody's had 10 cases of strep, I'm like, no, not it's just possible. You have to be really unlucky to have 10 cases of strep pharyngitis. And you send out the ASO when the strep test is positive, and it's totally normal. They're a
yeah.
carrier. They're a carrier. And
Yeah.
it's don't let
But
your
then
kid
what do
be
you do?
swabbed
Never
with.
swab them for strep again? What is the parent supposed to do? It
When
makes
they have
care.
pus in their tonsils and they
Yes.
have
Then you use the
102
clinical
fever
diagnosis.
and you have tender nodes, definitely swab them. But otherwise, wait to 2 to 3 days before you swab them. See if it gets better on its own. Because we treat strep to prevent rheumatic heart disease. And all these antibiotics into a kid 10, 15 times, because every time they go to the urgent care, they get swabbed, they get positive, they get treated, isn't exactly good for their bodies. So it's a mess.
Yeah, but
But
try telling a mother on Long Island that's coming in with their kid of school age that that has a sore throat, that, you know what, I don't think you have strep. I'm not going to swab you. I promise. She's coming back in 2 days with daggers.
I don't think
Am
that's
I
the
wrong?
reason. I think the reason is simple. We become epic slaves. And so all we do is let the medical assistant do no thinking, do some testing, and then walk in the room, say, you got strep, here's your script. Next. That's really the reason, because we don't want to have a conversations because the conversations are difficult. And it's easier to just swab everybody so you're never wrong, quote unquote.
I have a
But if you
question.
have a conversation, you don't get paid for it, you take more time and you're going to be wrong, somebody's going to be mad. But that's better medicine.
Is it effective to tell them when it's appropriate to seek care and when you should sit and wait, when you should just treat with Tylenol and Motrin? Because the conversations that I have with people, at least it seems to me, they're on board with it and they're understanding it. Listen, ear infections, if you're over 2, first treat them with Tylenol or Motrin. If they still have fever and pain after a day or 2, then it's appropriate to seek care for antibiotics. But you don't even need to look, you can save the copay. You can save by the way, this is not medical advice. Please, this is not a doctor-patient relationship, even though it sounds like I'm in your ear and in your head. I am not your doctor. Sorry. That disclaimer, because the lawyers, all these influencers out, I'm just going to get my soapbox for a second. All these influencers out there giving bad advice, do it with impunity. And yet we feel the need to always give these disclaimers. This is not medical, right? So, if they're over 2, you can try treating them with Tylenol and Motrin for a day or 2. And if the pain goes away, you don't even need to know if it's an ear infection. And so for some patients, from some parents, that's a huge relief, because they're like, oh, I just hate it when my kid's on so many antibiotics. Now they leave my office making it seem like it's a huge relief, but I don't know if they're going back to Dr. Rogu's office and being like, that Dr. Block doesn't know what he's talking about. He's telling me that my kid doesn't need antibiotics. I know my kid needs antibiotics. I don't know what happens after that visit. And is that what is your experience with that?
I think that old school model where the medical assistant swabs and the doctor gets a result and treats, I don't know, that doesn't exist here on Long Island. I don't know where you're talking about, Dr. Bravo. We have the conversation.
Now that's nonsense, because that's what you do at RBK.
No, we talk first. I swab.
The patients come in, they get swabbed, they get the test, they go home, you call them if they're positive.
But my conversation with them is always, I think this is probably a viral illness. Just to make sure, let's do a strep test. I think it's going to be negative. You take 2 Tylenol and call me in the morning. And if you don't get better, you come back.
Okay, and I would
nothing
argue
wrong with that.
Like
nothing wrong with that. We had the conversation.
I would argue, like Mick Connor says, if you think it's viral, why are you testing for strep?
Because that kid will be calling back in 2 days, 3 days, that he's still sick, and the doctor never checked for strep.
If it's viral, then the sore throat should be gone in 2 to 3 days, right?
So as
long as the symptoms
they always call it 2. They always seem to call it 2.
Can I make a suggestion? This is where I think a utilization of the medical assistant would be good. You just say, hey, this is calling from Dr. Rogu's office. He just wants to make sure that your child no longer has a sore throat. If they do, I'll have him give you a call. If they don't, then we're so glad that they're progressing as expected. Like, that seems like the kind of thing that you could outsource to a medical assistant, because you're not asking them to make a medical decision. If you're asking them to swab your patients, you're asking them to use clinical judgment, which is beyond the scope of a medical assistant.
Right.
Yeah.
I know for efficiency's sake, sometimes it makes sense, but.
Have you seen what the ERs do now? It's ridiculous. You see a patient chart and they're there because of an appendicitis. They get the $1,200.
Yeah.
Viral.
And you're worried about a little $3 strep test. Come on.
And it comes back positive for some virus I've never heard of. And it's like, there's no treatment, nobody.
It's good medicine. It's good medicine.
The viral panel, I think there was some benefit. So we were doing that in like the height of COVID, right? We were sending all these viral panels, because if it came back negative for COVID, you still didn't know if it was a false negative. But if it came back negative for COVID, but it came back positive for rhinovirus, then you're like, okay, now, I mean, it could have still been both viruses running together at the same time, but at least you were a little more comfortable telling them that it wasn't COVID, that it was rhinovirus. We stopped because those panels are expensive and not covered by a lot of insurances. But like during the height of COVID, I think it was informative for patients to really be leaving there with something that they could sink their teeth into, like adenovirus, right? There was a little confusion there at some point with adenoids and adenovirus because they sound so similar. That became a little confusing for some patients, but we had to work on the spiel a little bit to make sure that there wasn't any confusion. But that's beside the point. I think there is sometimes benefit to sending that viral panel, right? Like, I don't want to throw my emergency department colleagues under the bus for doing what they think it's hard to be in their shoes. I've never worked, aside from when I was an intern, I've never worked in an emergency department.
So yesterday, check this out.
I had a team of PT emergency room doctors, and when I was doing it, there wasn't even a rapid flu test. So it wasn't available.
Yeah, in the emergency room, they don't have strep tests, by the way. Do you know that?
Really?
Yep.
It has to go up to the main lab.
Yeah, it takes
because
throat culture.
This is not a plug for the company ID Now, but we have those ID Now, I think.
Yeah, but you don't work in emergency room.
I do not work in an emergency room.
So
here's about the emergency room.
Here's the thing about the emergency room. They have a highly complex lab license. You can't run a test in I can't. Dr. Bravo cannot run a test in the emergency room. It has to go to people that are trained and are tested and are proficient in running rapid streps in the main lab.
Got it.
And wherever that main lab is, somebody has to put it on those vacuum things or walk it over there. And then it gets into a pile, and then somebody does it. It's got to be logged in, and then it gets back on the computer. So a rapid strep in the emergency room can take an hour to come back.
The strep is tricky. We had a kid that was in the emergency room for belly pain, right, lower quadrant belly pain. They admitted it was wishy-washy back before the CAT scans. The kid's exam was pretty good. Surgeon didn't want to do surgery, admitted him for observation, and he had significant abdominal pain. 2 days later, the throat culture comes back positive, started him on some antibiotics, for positive for strep, started him on antibiotics, belly pain went away. A month or so later, he comes back again with belly pain, looks like appendicitis. And I remembered him, said, did the rapid strep was positive, didn't get admitted. Strep is really tricky sometimes.
You know what? I have trouble knowing what the right thing to do with those particular patients where they come in with abdominal pain as their main symptom of strep.
Yeah.
Because some of them, to Dr. Bravo's point, will come in with 8 episodes a year, which is above the American Academy of Otolaryngology criteria for strep, right? It's usually these by Dr. Paradise, who was a pediatrician in 1981, came up with these criteria for tonsillectomy, and we still use them, which is 7 episodes in a year, 5 episodes a year for 2 consecutive years, or maybe 3 episodes a year for 3 consecutive years. And if you've got a kid with abdominal pain over and over like that, and they come in and they're strep positive each time, right? I have to have this conversation with the parents. Like, yeah, I can make the tonsillitis go away, but I don't know if the abdominal pain is going to go away, because how is the strep possibly causing abdominal pain? And yet something that I see in my practice
it's
fairly
reactive. It's a reactive adenitis.
Yeah.
That's what it is. It's a reactive adenitis. But I had the opposite of your experience many years ago when I was the director of the pediatric emergency room. I saw a kid in the morning, a Hispanic kid, maybe 8 or so, with abdominal pain. No, not really guarding a rebound, but just a little concerning. And sure enough, he had injection of the pharynx. I did a strep test. It was positive, but I wasn't reassured by the physical exam. So I called the surgeon and I told him, I know he's positive for strep, but I got to call you because I'm not comfortable with the abdominal exam. He said, you're doing the right thing. Put him on antibiotics, give him my number, tell him to come back to the emergency room, have him call me if the belly pain gets worse. Which is totally reasonable, because most of the times it's going to be what George said. It's going to get better with antibiotics. Not this kid. He came back after my shift was done. We used to work 12-hour shifts, and my partner saw him. And now he had frank right lower quadrant pain with rebound. And the surgeon came in, and I'm like, oh, no. Now I have to go in front of the quality review people at the hospital and explain why I sent this patient home. And my senior partner was an adult, said, you did everything you can do. You called the surgeon, you documented, you told the parents to come back. Sometimes you just got to give disease time to evolve to give you the right diagnosis.
Yes.
And it would have been great if the surgeon had come in when you first called them in the morning, but that's his call. That's not your problem. You didn't think this kid needed to go to the operating room at that minute, in that moment.
And it's not your job to decide who needs to go to the operating room. It's your job to decide who needs to, when to call the surgeon and when not to call the surgeon. And you can either call the surgeon too many times or too few times. You can't call them the exact right number of times. I say this all the time. I would rather see too many patients referred to me by the pediatrician than too few, because if I'm seeing too few, then we're missing a lot of kids that would benefit from my intervention.
Expertise. And it might not be surgery, just the conversation. You don't need to worry about this.
Exactly. And people assume that if you're coming to see the surgeon, it's like you're going to have surgery that day. No, you're just going to see me so I can weigh in on it through my particular lens of expertise. We're not forcing you into the operating room.
Yeah. But even with this abdominal pain and the ER, how do you respond to a question? You have abdominal pain. To me, it doesn't look like an appendicitis. How do you know, doctor, that it's not an appendicitis?
I have an answer to that.
That's a tough one.
I've got an answer to that. Yeah. Because one of my boys had his appendix out this summer while they were visiting my in-laws. I wasn't there. I was here working, seeing patients. My wife and kids were staying with my mother-in-law, who lives in Switzerland.
Nice.
My son was having abdominal pain that seemed to us like gastroenteritis. And I looked in the literature to see if you can tell the difference between enterocolitis and gastroenteritis or appendicitis. And the literature seemed to point at, no, it is really hard, especially within the first 24 hours. Now, gastroenteritis usually goes away in 12 to 24 hours. So post 24 hours seems to be a good indicator, but this kind of goes back to what But Dr. Oga was saying at the beginning, like you need to give these things time to evolve so we can actually know what they are. Because early in onset, abdominal pain could be a million different things.
But now they get CAT scans.
Yeah. Actually, not in Switzerland.
Not in Switzerland, but over here they do. And that's how, try to talk a case that goes south and you didn't do a CAT scan. You got a problem, doc.
Yeah.
You got a big
So I
problem.
have a question for you. So what do they do in Switzerland? Still just clinical?
Clinical.
Okay. Yeah, it's very interesting. And we have to get back on subject because all these things are so interesting to reminisce about. Because I'm going to share it's not nice words I'm going to use, but when I was a medical student, I had an internal medicine physician who said, "You're not going to be an internist." I said, "No, you're just doing this because you have to get to be a pediatrician." I said, "Yep." He goes, "All right, I get that. So I'm just give you one life lesson that will serve you no matter what you practice." I said, "Okay." He said, "Don't ever tell anyone when they're going to die because they'll live long enough to come piss on your grave." And those were the wisest words I have ever heard. And I don't say it like that in the exam room. What I say is, I am not in the business of predicting the future. So I don't know what's going to happen tomorrow. But here are the things that worry me if you have belly pain. And if your kid happens to have those, call me or come back to the office. But I can't predict what the future holds.
You know what I couldn't have predicted? That a significant portion of this interview with an otolaryngologist would be talking about belly pain. I could not have predicted that.
Let's move on. It's
Sure.
about testing, strep tests. Strep tests are a $5 test, not a big deal. CAT scans are really expensive. And the rapid viral panel is really expensive. And we worry about a little strep test that gives a mother a good feeling that she doesn't have strep. I don't know what's right. I don't know what's wrong anymore. I try to make people better. Let's move on.
It's medicine.
Yeah.
Nothing's right, nothing's wrong.
Well, you do know what's right and you do know what's wrong. And if you struggle with that, you know you're doing the right thing.
Yeah.
If you see everything crystal clear, I guess you're having.
I had a case yesterday. The cousin went to somewhere, probably an emergency room, because they got the full rapid viral panel that was positive for rhinovirus. Emergently, the other 3 kids that live in the house have to go to the doctor because they were exposed to rhinovirus. They had a little runny nose. What do you do with that? You got a little virus.
Collect the copay, put holy water on their
forehead. You got a virus.
Move on.
You got a virus. I didn't do the rapid viral panel.
Okay? I can't. The world isn't perfect.
Yeah.
So now that, Dr. Block, now that we have these tremendous vaccinations, what does but before that, one thing that really bothers me is that you can have your tonsils completely removed and then you can still test positive for strep.
Yeah.
And then I don't know what to do with that. I treat them because what else am I going to do? But what does an ENTs do today when so many of the ear infections are gone, the recurrent sinus infections are gone since we started vaccinating with a pneumococcal vaccine? And I would venture to say some more of these ear infections and chronic respiratory problems will be lessened by the monoclonal antibody for RSV. So what do you do now in pediatric ENT?
First, I just want to make it clear, I'm not a fellowship trained pediatric ENT. I'm a general ENT, and a lot of my practice, actually the bulk of my surgical practice is peds, but the volume of because kids tend to have surgical problems, adults tend to have non-surgical problems, but I do see a lot of adults as well. I think the vaccines are working better in Virginia than they are on Long Island, from what you're describing, because we see lots of sinusitis, we see lots of otitis media, we see lots of enlarged tonsils and adenoids. We're seeing kids getting viral upper respiratory tract infections that lead to adenotonsillar hypertrophy. Actually, it's hyperplasia technically, but we call it hypertrophy. We're still seeing all of these things. I do tons of ear tubes. I do tons of adenotonsillectomies. I do sinus surgery on mainly adults because these things are still a problem and a common problem. Less frequently in the summer months, certainly, but school started again. You're going to be seeing tons of them. You know, my schedule is going to be filled with ear tubes, tonsils, and adenoids again very soon.
So from your perspective, you haven't seen less consults for tubes than you did maybe 10 years ago?
No,
Wow.
no, I haven't seen a significant change. Also, 10 years ago, I've been in practice 13 years. So 10 years ago, I wasn't as busy as I am now. So now I've gotten a reputation. And so a lot of people are getting referred to me. So I'm seeing a lot more. Maybe other people are seeing fewer. I don't know. Maybe it's just the
But on
way,
Long Island,
the
it's
referrals
become
work.
extremely difficult to get an ENT appointment with somebody that sees children. There's less and
Really?
less of you guys. Yes.
There's a
Maybe
quirk to
that's what it
that.
is.
Yeah.
There's a quirk to that. There was a particular brand of managed Medicaid that I take, and nobody east of me on Long Island takes. And George, you were east of me. And when Stony Brook University lost their pediatric otolaryngologist, I don't know if they've hired a new one yet. Basically, everyone who has that particular brand of, there are people who see adults that take that type of Medicaid, managed Medicaid, but I am the only one. There are some people west of me, but I'm the one furthest east. And I'm in Nassau County, which means Suffolk, all of Suffolk. I was seeing patients from like Quorum and Riverhead that would
So,
drive to me because I was the only one that took this particular
so
brand of
going
medicine.
back to what you see nowadays, so you say a lot of your surgical practice still kids, tubes, um, tonsils.
Yeah.
That's what you do mostly.
Yes.
In the adult world, what do you consult for mostly then?
You mean, so surgical problems would be sinusitis and just nasal congestion from
Okay.
polyps or deviated septums and allergic rhinitis and whatnot. But adults come in with pain issues like difficulty swallowing, voice changes, dizziness, headaches, hearing loss, ear pain, all the stuff.
Oh, wow.
And so they tend to be non-surgical, except for I don't do head and neck cancer. We've got great academic centers near us that do tons and tons of head and neck cancer. So I didn't think it made sense for me to like dabble in those things. That stuff I see and then refer to the academic centers. But that's what adults tend to.
Which one is more rewarding for you? Because to me, one of the nice things about old school pediatrics is that you had strep, you give them the antibiotics to get better. And I think the surgical specialties are to some degree immediate gratification. The person who can't walk, you replace their knee, 6 weeks later they're walking and it's awesome.
Yeah.
The kid can't speak because he doesn't hear. You put the tubes in, they come back 2 weeks later, and all of a sudden you can't tell them to be quiet because they don't stop talking. So which one is more gratifying to you, the surgical part or the medical part of ENT?
The surgical part is nice just because it breaks up the week. Like seeing 25, 30 patients a day, 5 days a week can be really taxing. So if it's broken up by the surgery, it's just a nice change. I would imagine if I was in the operating room 5 days a week or 4 days a week and had one day of office hours, the office hours would be a nice change because then I'd be interacting with human beings.
Yeah.
Not that we don't interact in the operating room. You know what I'm saying? So I think it's just the variety that makes the surgery a little more appealing because it's just, I don't spend as much time in the operating room as I do in the office. Also, one of my favorite things is the kid that comes in with poorly controlled asthma, enlarged tonsils, adenoids, fluid in their ear. They're not speaking so well. They can't breathe out of their nose at all. They're mouth breathing. They might even have failure to thrive because it's so hard to eat when you can't breathe at all through your nose. They're snoring. The parents find their every night terrifying because the kid's got such bad sleep apnea. They're coughing their brains out because of their uncontrolled asthma. They see me and we get that. I don't personally manage the asthma. We'll make some recommendations and then send it back to you guys, but we'll help all that. And then suddenly they've just got a new kid. You take out the tonsils, you take out the adenoids, you put in the ear tubes, you manage the asthma. Now the kid's sleeping, they're speaking, they're eating. The parents are sleeping, everyone's sleeping. Often kids, they can have executive function problems because of the sleep apnea, like ADD, like ADHD, like symptoms. And then the kid's behavior improves. And it's for something that's not complicated, like taking out tonsils. We've all done it over 1,000 times. When you finish residency, you've done a few hundred adenotonsillectomies. You've done a few hundred sets of tubes by the time you finish your training.
I haven't taken anybody's tonsils out yet.
An ENT residency. And so for me, those cases are the most fulfilling because it's not hard to do. And the complication rate is low. especially if you're shaving the tonsils instead of removing them completely. And the kids do so well, and the parents are so great. It's amazing. It's
Yeah,
like,
but I have only one time ever in my life seen a serious complication from a tonsillectomy on a kid that was obese that got his tonsils taken out. He had some kind of a weird bleeding thing, bled out. We had to code him on the stretcher. It was really, this is way back in 93, 94.
Yeah, so that's a total tonsillectomy. The bleeding risk from shaved tonsillectomies are like 1 in 1,000 because you're leaving a little bit of the capsule behind. But no, post tonsillectomy bleeds are a big deal.
Now, the problem that happened with this kid was not that the surgeon did anything bad, that the complication wasn't expected. Somebody told him you should look for bleeding. Access to care, that was the problem.
Yeah. Yes.
Couldn't get a hold of their doctor, couldn't get a hold of their ENT. So all they could do is end up in the emergency room after you bled out really bad.
Yeah. So yeah, the risk for tonsillectomy, total tonsillectomy, the risk is around 1 in 50 of a post-tonsillectomy hemorrhage in kids, 1 in 20 in adults.
Oh,
so it's a common complication.
So do adults, are you observing overnight, or you still send them home right after?
No, typical bleeds happen about 5 to 7 days after surgery. They can happen immediately after surgery. Like I had one patient who did it, that happened to them like in the recovery room, and then we brought them back to the operating room and stopped it. But typically it happens 5 to 7 days after surgery. So you're not just going to like keep them in the hospital.
No,
You're not going to keep all those patients in the hospital for observation a week later. It can happen. I've seen one happen 2.5 weeks later, which is like unheard of. But that's the furthest I've ever heard one happening after surgery. So, yeah.
Now, tell me more about your group, because I looked at your website and your medical group is huge.
Yeah.
So my group has some similarities to Dr. Rogu's group. And I feel like this is how private practice needs to work nowadays, which is you need a large group with people who want to run the practice and people who just want to see patients, and then maybe dabble in a committee or something to help their practice be as good as it can be. But I'm not sure what the numbers are exactly, but we're like 250 physicians, ENTs and allergists. We have an elected board that makes the decision. Everyone has a clear path to full equity partnership, which means when you join the practice, you know how you're going to make partner. And once they do make partner, they are on equal footing to me and to everybody else. There's no majority share partnership. Our founding partners decided this, and a lot of them have retired. If not all of them, the original partners have since retired, and they retire with nothing. Not with nothing. They've been practicing. They did fine for the years that they were with us. And because of the size, we're able to negotiate more than smaller practices could. But like they had the foresight to build something really incredible. And so
let me dig a little deeper.
I have 170 partners. So of 250 physicians, 170 of them are full equity partners. And so that just shows you that if you join us, and you do what you're told you need to do, you can become a full equity partner.
Wow. And then each partner has one share in the corporation or whatever.
Yeah, I own 170th.
Oh, wow. Well, that's amazing.
And how do you guys get decisions done?
The board.
They vote.
Okay. The board makes decisions. And anytime you need to make a major decision, then that might come to a vote of the partnership. But those are pretty infrequent. I actually don't know if I can remember a vote occurring anytime in the recent past. But the board takes care of really everything.
How many states are you in?
I'm sorry?
How many states are you in? New Jersey, New York, or just
New York and New Jersey? Just New York and New Jersey.
New York and New Jersey?
Yeah.
Okay. And how many? So you said there's a board selected by the partnership. How many board members do you know?
7. One of whom is an allergist. The other 6 are ENT, because just the way our practice works, each office has one allergist and the rest of the offices are ENTs. So we have 50 offices, probably somewhere from 45 to 50 allergists, and the rest are ENTs.
Wow. And do you ever get all together? Like I saw this once when I was in Orlando vacationing. There's like a multinational law firm, and they had 2,000 partners. And once a year, all the partners from around the world come to the same place. And for 2 days, they have it looks like a CME event. Like it's just 2,000 people in an auditorium, and they come together and they all talk about legal things and managing the practice and stuff, because they got partners that are specialized in employment law, others in discrimination, others on the Constitution, but they get it together once a year so that everybody can get to know the full breadth of what they're doing. Do you guys ever all get together in one place
We
and
do.
talk? Yes.
We do. We have an all partner meeting, and then we have an all physician meeting. So that it is exactly as I said it. Once a year, maybe twice a year. I think once we get together. As being 13 years in this practice, I should pick up on the pattern by now. But it's either once or twice a year that we get together as partners, and then once or twice a year we get together as physicians. And we try to make it somewhere central. But when you have an office in Southampton and an office in Middletown, finding middle ground can be challenging.
Yeah.
Wow. And then I was looking over your C-suite. In your C-suite, there's only one physician, and everybody else are non-physicians.
Yeah, no, our C-suite has no physicians. We have
I
a
thought there was-
president.
Yeah, the president. So the president, not a C-suite member, like he's not in the daily operations.
No, he sees
Okay.
patients full time.
Okay.
Or maybe, I don't know how often, I don't know his schedule, but maybe he sees patients 4 days a week instead of 5, because he does have a lot of responsibilities. Or maybe he sees patients 5 days a week, but is more inclined to take time off here and there because he's got so many responsibilities. But he is not in the he's not in the weeds, because he can't be. He can't be while he's running a practice, while he's got his own practice. So all the physician board members still see patients full time. And so they're not going to make a decision. So you might be working for a hospital system that's, listen, our patients want to be seen on Saturdays. You need to start working Saturdays. Because if they say everyone needs to start working Saturdays, they need to start working Saturdays too. And so it's optional for those who want to work weekends, but it's not mandatory, because then they would need to do the same thing. So they're not going to do something that's going to move the bottom line, but actually make their quality of life worse. So it's nice to have that type of leadership. But the C-suite, they're amazing, but they still answer to the board. So the board doesn't have to spend their time on minutia. That's where the C-suite comes in, because they're making sure that our practice runs smoothly. So if something happens, the computers go down, we've got a small army to make sure that gets up and running, and then to troubleshoot that so that it doesn't happen again. That's the C-suite. Our CFO is amazing. Our CEO is amazing. Our company was really built by the CEO who recently retired. Him and the founding members really built this practice into what it is. We have a new CEO who I love. His name is Dan Blum. I think he's incredible. And he's taking this practice to amazing places. And so we've got a CEO, a CFO, chief strategy officer, chief technology officer, a really robust C-suite, but ultimately they answer to the board.
All right. That is very interesting.
Yeah. So I presume you guys are all one tax ID number, right? Or they're
Yes.
individual. Yeah.
Yeah.
Well, and then no, I don't want to be inappropriate, but is each pod,
Where are you going with this?
well, is each pod each what they kill? Because we've seen both models. So for example, in San Diego, there's a pediatric supergroup, probably one of the largest supergroups in the country. It's a little different than what you're describing. They have almost 300,000 kids that they take care of in San Diego, but their C-suite is mostly physicians, and they do stop seeing patients because they're managing the company. And they made a decision that all their physicians will be paid the same, because they were concerned that some of the practices were in neighborhoods that needed care, but because of the payment by Medicaid, they couldn't make the same. And as if your office was in La Jolla and you were seeing all insured patients that pay their bills.
Yeah.
And other practices go, no, we don't subsidize practices that are underperforming. You make a percentage of what you collected every year. Is yours more one way or the other?
Both.
Both?
So we have fixed expenses and variable expenses.
Okay.
And the fixed expenses tend to be the same. And we decided a long time ago that even though Manhattan rent is much more expensive than Long Island rent, that would be spread out among the among the practice. So if you have a bigger office, you're probably going to have a bigger, nicer office if you're in Suffolk County, because just rent is not nearly as much. But that we're not going to be changing the fixed expenses that way, that everyone's got the same fixed expenses, but variable expenses tend to change with the volume that you see. So if you see a high volume of patients and you're needing medical assistance to stay after hours and things like that, then your overhead's going to be higher. But you've already overcome the hurdle of your fixed expenses. So everything that you keep above those fixed expenses is going to be, your income tends to go up considerably the more patients, the more you're able to collect. But
Right. There's a threshold, right? In the very
yes,
beginning, if you're seeing 5 patients a day, you're barely paying rent and you don't
yeah,
have anything. Once you get to 15 patients a day, anything above that really accrues to the clinician because
yes.
the expenses don't go up much if you see 15 or 25. Those extra 10 patients where you make your money. Fascinating, fascinating. Now, I was listening to one of your podcasts. You interviewed a transplant surgeon from California that moved to LA recently. And he transitioned out of medicine. And he basically, I think, was burned out. He said that the train was leaking oil, I think is what he said in your podcast. And I had to take a year off and refigure out what I was going to do. And it was curious to me that you said something, or I might have misunderstood that you were feeling that you were getting to that point in your own medical career.
We're coming from two very different places, right? He's a transplant surgeon and he's dealing with very high stakes stuff every day, life and death stuff. If an anastomosis leaks, like he's got to take someone emergently back to the operator. I don't want to make it sound like I was comparing my life to his, but I think that's something that a lot of us in medicine struggle with is, do I stay or do I go? And there is a shift in practicing physicians where everyone seems to have one foot, or a lot of people seem to have one foot out the door for one reason or another. I don't think most of us have it for the same reason as his. Like he decided he wanted to be able to spend more time with his family because he was just in the operating room all the time. Like I rotated for a month on transplant and I could never I could never do what they do.
I think for people who are not physicians, transplant medicine is critical care 24 hours, 7 days a week. The
Yeah.
patients come in sick, you operate on them, they're really sick, then they get a little better, but they're immunosuppressant drugs for the rest of their lives. There's never it's not like pediatrics, you got strep, I fixed you, or
Yeah.
ENT in pediatrics, you had too many ear infections, you're not talking, put the tubes, it's great. No more problems. They never stop.
Yeah.
They never
Yeah.
stop.
So I don't want to
And they
make it
can't
sound like I
skip.
was comparing my life
No,
to
no,
his,
no.
but
I
it's
was
just the
just
culture
curious
now.
because we talk about a lot about this, and that's why I was curious about your group. One of the things that the people in our industry, when I say our industry, people who serve pediatricians so we can do what we do, is the lack of advocacy, and not advocacy, but the lack of autonomy, and how that is really burning out physicians at an alarming rate. So that's why it's so interesting in your group, whether being such a large group that you feel like you're lost your autonomy. But what I heard you say is no, what you feel is like you have a lot of autonomy, you have a voice, you have good governance, and this is just allowing you to do what you like more.
Oh
As
yeah.
yeah. So that's very interesting. But when you said that, I think we all feel that way except George, right? That's why we create podcasts. That's why we do public speaking. George only likes to play the guitars on Tuesdays and Thursdays, but he'd be happy going to RBK Pediatrics 7 days a week and seeing patients.
But I see a bass in the background as well.
bass
So
too.
it's not just guitar.
Yes.
Yeah,
I
yeah,
pivot to anything and drums.
and drums too. But it's something that puzzles me and what it is that we're doing because people say the peak of your career is sometime in your mid 50s. That's when people get really good at whatever they're doing.
Yeah.
They've got the wisdom of experience. They're still fairly young, competent. They still have energy. And as you said, many physicians are reaching their late 40s and going, I don't know if I keep doing this, even if they're not doing transplant medicine.
Even if I can't, I don't want to. Even if I can, I don't want to. I think that's what I'm hearing from a lot of physicians is like,
Yeah.
It's just I'd like to do something else. That's why there's the rise of the side gig with you guys with your
Right.
podcast and me with my podcast. There's
Yeah.
because we have other things that we want to do and can do, and maybe in previous generations that energy was spent growing and managing a practice, and so you would have. Or if you worked in a hospital, it was climbing the ladder of leadership within the practice, and not just seeing patients all day, every day. There was something else that
Yeah.
was that you had to use to grow who you are, that changed from day to day, because we tend to see the same things over and over. And so it can become less intellectually stimulating. And then you go looking elsewhere for that stimulation, and hence the side gig. Or you feel like you're trapped because you're working in corporate medicine and you need to find a way to get out. And so you work on other revenue streams that can give you leverage to maybe work less or have your practice in a different way. I think there are a couple of factors here.
When you're in an independent practice, you can do different things. When you have an idea, you just do it. I got bored in, I think I got bored in general pediatrics. So I developed medical school students. They come and they rotate with me. I teach them a little bit. I still see my patients. I work full time. You got to do things. I don't think you can just do like the old timers. I'm going to work here until you find me dead on the chair.
I'm going to retire and I'm still not going to leave the doctor's lounge.
Yeah.
I'm going to come back here and continue talking at people.
Yeah.
Yeah. Yeah. I don't know. I do know this is how I feel. I don't know if other people feel the same thing. Pediatrics is a difficult specialty because it's a physical specialty.
Yeah.
You have to walk from room to room. You gotta sometimes wrestle the kid down to look in his ears.
I got bitten yesterday. You believe that? We were wrestling the kid,
I do.
holding him down for a strep test for that stupid $5, and the kid bit my belly.
The belly.
Yeah,
It's quite a place to
hovering
bite.
over him.
Yeah.
You just got me.
That's pretty funny.
Are
It
you
wasn't
up to
funny.
date on your rabies vaccine?
It wasn't funny. The students thought it was funny, but
Yeah, I think it's funny, but that you do realize as a physician that aging is a real thing, and being on your feet for 12 hours for a 12-hour shift, which I used to do when I was in my early 20s and 30s, is not going to be a possibility in my late 60s. It's just my bones are going to be tired. And but I don't want to just sit home and do nothing. So I think for me that's part of the pivot, which is what will I be doing when I'm 75? I don't want to just be sitting in the
Or 65
library.
or 55, like to George's point. I think it's important that we talk to medical students about this and our
Yes.
trainees about this. That like you need to have outside interests that either can be part of medicine that you can integrate into your medical life, kind of like we're doing with this podcast, or outside interests that are completely unrelated that you can use to continue growing and challenging yourself as a person, or maybe both, because there is going to become a time where the stuff that you do becomes mundane.
yeah.
And some people
Yeah.
find that in academic practice, right? They're doing research, they're pushing the limits of what can be done in the operating room, or they've got research grants and they're trying to they're finding their interest that way. And in us, it could be running our practice. Like I help with patient experience. And so I take the wisdom that I've gained from 450 episodes of podcasting, on a lot of which were about communication. And I'm using that to help my practice grow and improve with patient experience. I think it's important to have and cultivate, and it's important for our trainees and our students to recognize that this is going to be important, that they can't just rely on medicine and seeing patients. There needs to be something else that they need to have an eye on and interest in so that they can cultivate it and they can continue to challenge themselves and grow as a person and a professional.
Yeah,
I
but
think
what I
you're-
would see with that, you're doing patient experience, engagement, reviews. I saw on your website, everybody has a lot of reviews. That takes time.
Yeah.
And when are you going to do this? Because you're busy seeing patients. I need a dedicated day to do this stuff.
But then I'm not getting revenue
And
because I'm not seeing patients.
exactly.
Right? If I take a dedicated day to do this, right? Like right now, we're recording this. It's 10 o'clock in the morning on a
Yeah.
Tuesday.
Yeah.
I had to take half a day off in order to do this. And so that's lost revenue. How am I going to balance? I think what you're asking about is work-life balance.
Yeah.
Is that where you're going with this?
Yes. So
I just think I think sometimes too, when you're doing something that you're passionate about, that's playing the guitar or doing the podcast or patient experience, people have different passions. You may lose the revenue of these 4 hours that we're doing to prepare for the podcast, taping the podcast, so forth. But you're re-energized so that when you're back in the exam room, you are doing so much better and you're so much more efficient because you have energy again. And people, I think, do not give enough importance to that, which is if you fill your passion buckets, you have more energy to do things that you're good at, but you're no longer, it's mundane work. I don't need to see another ear infection or another strep throat in my life, but it doesn't bother me anymore because I have the things that I'm trying to get good at. And this is just what I do to make money and help people.
But it's
Well,
going to take a piece out of your paycheck. So I think for
it is.
me, it's yes, it's important to pursue what you're passionate in. And it's also important to keep an eye on your why. And one of the things that I've tried to do with this podcast and is grow the audience to the point where I can get sponsors and then have those sponsors pay enough that I can scale back on my clinical time. And if I can scale back on my clinical time, then actually I can actually spend more time with my kids. But what happened was I ended up dedicating more time to creating and growing this podcast. I didn't scale back on clinical time. And then I'm spending less time with my kids because I'm doing all of this. And it made me, at one point, I realized what was happening and I just stopped. And I was like, I have lost my North Star here. Like a lot of the idea was so I could work less, so I could spend more time with the kids. Now I'm spending less time and my kids at a critical age, I have 3 boys in elementary school right now. And I need to be spending time with them. And so every so often, if I need to scale back on my hours to do something with them, I'll take the hit on revenue. We're fine. Or if I need to just not concentrate on the podcast as much, not spend so much time doing it and building it and growing it, I will do that because I at one point lost my way and it was taking away from family time, which was part of the reason I did it to begin with, was to get more family time. And I think it's important to know your why and follow your North Star. Why are you doing this? Why are you doing that? And then go from there. Yes, I will need to work longer because now I'm working less, but there's going to be a point when they're teenagers and they just don't need me as much. And I can scale up on the hours then. But
Yes.
now now is when they need me the most. And so like I have no problem taking time and not contributing so much to my savings and my 401k and whatever, because like I know how interest works and I know how compounding interest works. Thank you very much for all the personal finance experts out there. But right now, this is time I'm never going to get back. And so I
correct.
think when you're making these decisions about work-life balance, it's really important to know that there is going to be a trade-off. There's always a trade-off. Time is not infinite, but know your why, have your North Star, and follow that.
So time is the only commodity that cannot be made up, made back, made up.
Mhm.
Time is gone.
Yeah.
Money can be, you can always find another way of making money, but time not. So why did you start the podcast other than as a way out to have more time with your family? There, not that piece of it, that the
That
idea.
actually wasn't even the reason. That wasn't even the reason. It's just that because I've been podcasting so long, I have 450 episodes. It would
Okay.
be
Yes.
nice to be able to turn this into something that I could monetize. Really, it was because I had trouble making my way through my day efficiently. So seeing 25 to 30 patients a day, every day, I had trouble communicating in ways that the patients were found satisfactory and were also efficient. And I knew that there were people out there that were experts in communication, but they weren't focusing their lens on physicians. They were talking about sales, closing sales, making deals, or leadership, or a lot of them dating. It's funny that you could take parlay someone who is an expert in helping people like be better at dating. That communication strategy can be parlayed into improving communication with patients, right? So there's a lot. Eye contact applies to both. So that's why I created the podcast, because I wanted to take these experts and focus their lens on the doctor-patient communication. But you can't just create a podcast out of nowhere. Like I couldn't invite these ultimately strangers onto a show that didn't exist. So I had to create a show first. So what I did is I reached out to my immediate network, who, being physicians, we have a network that are experts in lots of stuff, whether they're our friends from college or high school or med school or residency, but we've got lots of experts in our Rolodex. And so I reached out to some of my friends who were experts, and I did an episode on advocacy, one about common misconceptions about the Affordable Care Act. I had a gastroenterologist just telling us what she wished everybody knew about gastroenterology. We did a medical device. I have a friend who's developing 3D printing for medical devices. So we had an episode on medical device development. And so I created the show first, and the topics exploded from there. And so the tagline is everything we should have been learning while we were memorizing Krebs cycle. But a lot of it I ended up taking back to communication. And so I have a lot on communication, whether that's nonverbal cues or persuasion or how to get someone to like you. You're someone who wrote a book, How to Make People Like You in 90 Seconds or Less. And so we took his expertise and focused it because we don't have a lot of time with our patients. So how do we make this communication satisfactory to the patient and yet still efficient? So every time I do the interview, it's through the lens of efficiency also, because the reality of the situation is we have finite time. So we need to use that time methodically. And so the big misconception in our business is that in order to improve your patient satisfaction scores, you need to spend more time with the patient. And that is not true. You need to be methodical about your communication, just like we're methodical about everything else we do. We are relentlessly methodical people in medicine. And so we need to be that way in the exam room too. And it leads to less stress, more connection, a better experience for the doctor, and a better experience for the patient.
Interesting.
Absolutely.
Herb, I guess our podcast is about storytelling. And that's all these things are, I'm thinking about it, that's all that business stuff that you learn in MBA school. Eye contact, communication, storytelling.
I have an episode on storytelling. He just gave as a Toastmaster, and he's also a retired neurologist, and he gave some stuff that he learned from Toastmasters and is able to apply to being a doctor.
What is your podcast name? What is
Physician's
the name of your podcast?
Physician's Guide to Doctoring.
Oh, cool. I'm sure our guests will watch it, listen to it.
I hope so.
Yeah, the communication piece is not part of our curriculum in medical school or residency, and it's such an important piece of what we do as physicians. But we only learn it later on our own, which is
we do, or we take cues from mentors and we try to figure out how they do it. And sometimes they know how they do it, and sometimes it's just something that they've developed their whole life, and they don't know how they do it. So they don't know how to replicate it. So this is why I try to break it down into its pieces to try and help people to, I'll give you an example. Nonverbal communication, nonverbal cues. I tell people you can break it down into, and I learned this from a world champion poker player who teaches people about nonverbal communication because he does it outside of just the poker playing world. And so one of the things that I spoke about was breaking down nonverbal cues into interest and authority. And interest you convey with your facial expressions, and authority you convey with your vocal tonality. And so if you want a patient to really know that you care about what they're saying, you need to use your brows. Raise your brows, lower your brows, furrow your brows, squint your eyes, just this top half of your face. That's all you need to do. Now, you don't force it because they can tell when you're just making it up, right? If you don't actually care what they have to say, you can't fake it. They'll pick up on that. But if you care, but you're not moving your face, they can't tell that you care. So you have to remember to actually move your face appropriately. And then authority you convey with how you use your voice. More of a staccato form of speech, taking pauses. You can use silence to your advantage. There are ways to use your speech to convey that you are the authority in the subject matter. So you can break it down into, this stuff can be broken down into digestible ways that physicians can then apply to their practice. Because we're losing the trust war out there. People think that we're in the pocket of big pharma. You see it all the time online. People are not trusting physicians and healthcare the way that they're used to. They think that we're all in it for the money, and so we have to, the battleground is these one-to-one interactions where I think we can really win them back, but we have to be methodical in the way that we communicate.
I personally think that the evil of medicine is that darn computer. All right. That has taken away the relationships, the connections, the communication, the storytelling. I have medical students, so they're very green. It can't get any greener than a third-year medical student in September, right? They're very excited to come. They're very excited to sit in front of the computer. They're very excited to type to me. And they freak out when I tell them, don't worry about that. Talk to the patient.
Here's what's coming next. Here's what's coming next.
The AI scribes.
Yes.
That's
ambient AI.
That has changed my life. I use it. They walk in with the phone. We put it down.
Which one do you use?
We use Freed AI.
Freed. I know Freed AI. Yeah. They're great.
Put it down and the student starts talking to the patient, just engaging the patient. I still feel that they have to type a little bit, especially a third year.
Oh yeah.
But they don't have to like worry and get every little detail that they may miss. And then they do the whole thing, and then I walk in, and then they present the case to me, and I says, you don't have to remember it. Look at the computer and use the computer as a tool. Tell me what medicines they have allergies to. Tell me what is their problem list. Then I'll go in, I'll ask them some more questions. We'll examine, we'll make a diagnosis, we'll make an assessment and a plan. And do you have any more questions, Mom? Usually everybody's happy.
Yeah.
And my progress note, I'll go back and I'll just drop them into the EHR later. No stress.
Yeah.
No stress. It's life-changing. What's very interesting, I can't get a lot of the doctors to use it. I got templates. I got this. I got that. I don't need it. I don't know.
Yeah. The same thing happened to us with our dictaphones, right?
Yeah.
That all of us now use. And you take it away from them and they feel paralyzed without it. First, you have to force it on them. It's like my kids.
Yeah.
I don't want to go. I want to stay here. I want to stay at home. I don't want to go to the park. I want to stay at home. You take them to the park. I don't want to go home. I want to stay at the park. Like once they're committed to it.
Even our illustrious Dr. Bravo, I practically bullied him into trying it. And now, how's your life, Dr. Bravo? Come on, it won't kill you. Say I was right. Say I was right. Come on, I don't hear it.
The problems in the exam room are that the EHR that this clinic uses is not easy to use, so I can gather the data I need to have the conversation. The AI large language model helps in that I don't have to put a bunch of clicks in a bunch of places. But at the end of the day, the EHR prevents me from being the best doctor I could be.
I think these things are going to evolve.
Because it doesn't present me the data that I need in a way that I can then, because I think that's what a doctor does, right? I'm basically a translator. I get a note from you that says why you're not doing the tubes and what the plan is. And the parents following up for another reason, they're like, I wasn't convinced with Dr. Block. And if I can have that information as to what you're thinking, then I can explain to them why that's a good course of action. But if I can't get to that information quickly and I'm fumbling through a computer to try to get to where it is, and it's a pop-up window that's too small to read quickly, and the note was generated by Epic, and there's 5 pages of notes with social determinants of health, and patient was counseled about smoking. Like he's a 2-year-old, he doesn't smoke. All these other things that get populated by Epic solely for the purpose of billing more. I can't get to the meat. I just need the old-fashioned letter. Hey, Herb, I'm not doing tubes in this kid yet because it's the end of spring. He probably is not going to have any colds in the summer. If he has a cold during the summer, I'll see him back. I'll put the tubes. If not, we'll see what happens next winter.
What you're saying is there's someone else on the other end who's not using the AI scribe, who's not using ambient AI, because the way that the ambient AI works is it puts it in a narrative that is easier to decipher what's going on. It's easier to know what's important. And this is not like it's just the last iteration. And I'll tell you, because the guy who runs Freed, his wife's a doctor.
Good.
His wife is a physician.
This isn't
so she's going to be in his ear telling him the issues, and they take feedback from physicians all the time and then integrate it in the next iteration. And so it's going to keep on improving.
This isn't rocket science, right? For those of us that are old enough that we dictated notes to our referral physicians, it was concise. I didn't need to tell you that the kid had a heartbeat. You know that. It's your patient. You sent them because he had a fracture. I'm going to tell you, I saw him in the ER. The radiologist says he has a fracture. The orthopedic surgeon put a cast on it. He's going to follow up. You don't need to worry about it. Thank you for the referral. Next. That's all.
But that's the purpose of the Freed. You don't have to type all that nonsense.
You just talk. You have a conversation.
You just talk. Forget about the little buttons in between.
I understand, but that does it. Freed is a great product. And I think it's a great product. What I'm telling you is the architecture of ECW, which is the EMR that this practice uses, makes it very difficult for me to look at that clean letter that you sent or Dr. Block sent that I need to try to figure out to see what I'm going to tell the parents.
Yeah, but those are all documents, Herb. I get paid.
Well, George, that's what I do for a living. If I'm seeing,
I know, but it's not going to change. You're not changing the world. Epic is not going anywhere. All right, you're still going to get 500.
George, you're saying if this changed my life? No, George, because if I have a diabetic in the practice, they're here for their 3-year-old physical. I need to try to decipher what the pediatric endocrinologist said about their diabetes, what the plan is, and if it's 7 pages of nonsense, and I can't get to the assessment and the plan going on to make sure that the mom's okay with that plan, I'm not doing anything.
All right, so that's
we're talking about two different things.
So what you need to do is you look at the document, you review whatever things that you think are important, but not in your head. You say it out loud. You know, the patient.
George, you're not getting my point. I'm not dumb. I can do that. What I'm telling you is I need that information in a way that I can consume it quickly because I don't have an hour per patient.
Yeah, you're not going to get it for the next 10 years.
And if you cannot have it in a way in the EHR that I can consume it quickly so I can translate it to the parents, reassure them, tell them Dr. Block's in the right path. We don't want to put the tubes in the summer. That's why I send you to him. We don't need to be aggressive. There are always complications.
But you're suffering from perfectionism. You're never going to get it. 80%.
Not perfection.
Here's the other end of the AI is that you can ask it from the note. Not yet. But it will happen. You can ask it from the note. Take a look at this note. Give me a 2-line summary from the pediatric endocrinologist. And it will go through all the garbage that have been recorded for quality assurance and to make sure you're hitting your MIPS score or whatever it is for your hitting your reimbursement. Yeah. And then it will tell you what it is. And you have to decide as the physician, does it seem like reasonable or not reasonable? Because ultimately it's on you. But it's also, I would argue, because that person is probably not using an AI scribe. And so there isn't a concise summary. So George's point is that it's going to make your life easier when you are interacting with the patient because you don't need to face the computer. You can make eye contact. You can examine the patient. You can talk to them while you're examining them. And that's it. Is it going to help you review notes of other doctors who aren't using ambient AI? No, not yet. But there will be a point at which that can happen. It just hasn't happened yet.
And the trick there is a little difficult. And this is by EHR, right? So ECW stores all the consultant notes as a PDF file.
They all do that.
But it's not easy to take that file and dump it into AI to get a summary because it's a PDF file. Okay. So I don't know what they're going to do in the future to be able to bridge that, fix that.
Actually, I already solved that problem. As Dr. Bravo, I do international adoption medicine also. So I do medical records review. I just happened to do one from a country that I had 50 pages of dribble and it was translated from Spanish. So there's like all this legal translation stuff that's in there. I read my process was I would read the documents. I'd highlight what's important in yellow. It'd take me about an hour or two to read all these things. Then I would take them tomorrow and whatever was yellow, I would transcribe into a report, a summary report, so that I can make an evaluation and having a conversation with the parents that was intelligent. So recently, what I did is I took that document, I dropped it into one of these PDF something summarizer. Let me tell you, this darn thing summarized the thing exactly what I read, put it into a nice 3-page summary. And then it was something that I read that the thing didn't have. I said, so what about that, the status of that person? What happened with that? It went back. Yes, we found this stuff, and the status was that it was already tested and the patient was found to be negative, blah, blah, blah. That was really interesting. So my work that usually took about 6 hours ended up being about 2.
Yeah, and I think that's a potential. That's a
And I do
potential.
have to
That's a
add the
potential.
disclaimer that my podcast has been sponsored by AI scribes, including Freed. We always give our disclaimers with our lectures. This bears mentioning for
Our podcast is not sponsored by anybody.
That's not
We
true,
should have
George.
some sponsors. We do
That's
have
not
some,
George.
but not
We
this
don't-
particular episode.
Okay.
Freed is not sponsoring this episode.
No, Free's not sponsored.
Maybe they
everything.
should.
You told us why you started the podcast. How long have you been doing it?
6 years,
Wow.
6 years. And you have over almost 500 episodes?
almost 500 episodes. Yeah.
So you try to tape 1 or 2 a week?
Yeah.
Yeah. Sometimes I'll go on a blitz and I'll do 4 days a week. I usually record in the evenings. So after my kids go to bed, that as they're getting older, that is getting later and later and making my days longer and longer.
But
I typically record in the evening.
How do you get the doctors to come?
Sometimes I'll find people in Australia or on the West Coast, but sometimes it works for them and sometimes it doesn't.
Yeah.
And you talked a little bit about how you monetize it. You get sponsors to sponsor the show.
Yeah.
That is not an easy trek. You haven't got to the point where you make more money from the podcast than
No, and my podcast, it's like the Spirit Airlines of podcasts because we monetize everything. I'll send an email out to the listeners and that'll include some sponsorship information on it. It goes on my website. It goes on my social media posts. It goes on, we have pre-roll, mid-roll, and post-roll. And I have someone who does this for me. I'm not approaching these companies and negotiating sponsorship with them. I have someone who does this. She also manages, all I do for my podcast is I schedule the guests, I come up with questions, I record, and she and her team take care of everything else. And we are developing a podcast network for other physician podcasters, specifically physician to physician podcasters who are looking to have it be a plug and play thing where they record. Maybe we do their social media, maybe they do. It depends on how much you want us to take off your hands, and we'll do as much as you want us to do. There are different tiers of involvement.
Yeah, at least my experience has been that trying to monetize the podcast is incredibly difficult. The podcast itself doesn't feed off money, but the opportunities that it opens for public speaking and other engagements and consulting, that's where you backfill all the work that you have to do for the podcast.
Oh yeah. Oh no, I am so far in the red with this operation. This is not a money-making endeavor. For all the time, if I just spent this time seeing patients, I would be doing much better. I might be nearing retirement if I'd just been seeing patients that entire time. So this is not as much of a business as it is a labor of love. I'm just trying to, after 6 years, pivot it into a business.
Yeah, we are in 3 years, Herb.
We're not 3 years yet. This is our 3rd season. Yes.
3rd season. Yeah.
And I'm sure you do too. I get calls of people or ask me if they should start a podcast. And I tell them, you should if your heart's in it. If you think this is going
back to what I said before, your why. Yeah.
If you think this is going to make you rich and famous, I would try something else. But if your heart's in it and you enjoy talking to people and getting to know new people and you're curious about what they're doing and why they're doing it, and that brings you joy, it is an incredibly awesome experience.
Yeah. I was once told by one of these consultants that you will never make more money doing something else other than doctoring. He's right.
Yeah.
I don't think that's true. Some people have figured out,
Like what?
No, but there's
Maybe
some survivorship bias for all of this. There's survivorship bias. Like what you're seeing, what's visible, the successful podcasters. What's visible, the successful actors and actresses and musicians and artists. Like you're not seeing the struggling ones that never made it, that continued doing whatever it is that they were doing before, right? So there's a lot of survivorship bias around all of this.
Yeah, there are physicians who figure out either while they're still practicing or they pivot into another business line, and they're incredibly successful because they're smart people to begin with. And if they put an effort into what and passion into what they're doing, they can almost always come up with an idea that they're successful at.
Yeah.
I've taken a lot of your time. It's
Yeah.
been
Thank you.
very entertaining. Is there any question you have for us or anything I didn't ask you that you think people should know? I'll put you the link to your podcast on the show notes for people to find you and our social media posts. But other than that,
Just the advice I gave earlier, which was that you should be cultivating outside interests, whether they're adjacent to medicine, completely unrelated to medicine, completely within medicine, but something other than your day to day. You have to find what that is, and it might change throughout your lifetime.
Yeah.
But find what that is and give it sunlight, give it water, feed it, nurture it, and make sure that you just have something else other than this to cultivate.
Yep. Agreed.
yeah, thank you very much for your time. Really appreciate it, and I look forward to seeing you again.
Thank you.
Thank you so much for having me. It's been a pleasure.